My name is Corinne Kagan, the Senior Program Director at the Ontario Neurotrauma Foundation. And I'd like to thank you for joining us on this webinar. I think it'll be a very exciting discussion on LifeSpan, the transitions to adult services for youth with ABI and cerebral palsy. And our speakers today are Shauna Kingsnorth, Joanne Maxwell, and Dr. Mark Bayley. So I'd just like to tell you take a minute to tell you a few things about the Ontario Neurotrauma Foundation. ONF is a health research organization that focuses on the practical application of research. We work to advance, gather, and apply research knowledge. And our focus is on improving systems of care, outcomes, and quality of life for people with spinal cord and brain injuries, and to increase the effectiveness and use of prevention. ONF works with partners and stakeholder groups in Ontario and across the country as well as internationally. We pride ourselves on our relationships and our ability to initiate activity and network with many experts, organizations, associations, and agencies in neurotrauma and related fields. ONF receives its funding from the Government of Ontario and has existed since 1998. We always say that we have provincial focus but national reach. So I'm going to speak to our speakers today, and they are presenting on this joint initiative between Holland Bloorview Kids Rehabilitation Hospital and the Toronto Rehabilitation Institute of the University Health Network. Dr. Mark Bayley is the medical director at the Brain and Spinal Cord Rehabilitation Program at Toronto Rehabilitation Institute and brings the adult perspective to this grant and this program. He is an associate professor at the Department of Medicine at the University of Toronto, as well as working as an adjunct scientist at the Institute for Clinical and Evaluative Sciences, or ISIS. Next, we have Joanne Maxwell. Joanne is the project manager for clinical adoption in collaborative practice at Holland Bloorview. She's got status of the lecturer in the Department of Occupational Science and Therapy at the University of Toronto. She's also a clinical team investigator at Bloorview in the Research Institute. And third and not last, we have Shauna Kingsnorth, who was the study's investigator and worked with Bloorview Research Institute to do this. She's the lead of Evidence to Care at Holland Bloorview Kids Rehabilitation Hospital and took this role, I think, in the third year of the grant, so continued to stay very close to it, even though this was a four-year grant, and led the way for much of this project. Shauna is a status assistant professor of occupational science and therapy at the University of Toronto. So you're not here to listen to me. I'm going to pass this over to everybody now, the three presenters, who can tell you all about the LifeSpan project.
Thanks, Corinne. I think we were going to do some polling right now, right, David? So part of the presentation is to engage you in questions, and so you're going to be offered a thing on the right-hand side of your presenter thing, and we want you to tell us who's joining. So click on what you are so we get a sense of who the audience is today. We'll just wait for a minute because it takes a while for it to be completed. So it seems like we've got somewhat of a saturation. Oh, we're getting some more answers still. So look for the survey on your screen and click on what applies to you. Looks like we have about 20 odd answers. So we have obviously a large number of healthcare providers, people from one person from the community and nursing, and other people who represent 30%. So I hope you can hear me. I will speak up if you can't. So maybe this is very helpful for us to understand, and maybe we will move on to the next question, David, if it's okay. So the next question is to have us help us understand what are your learning goals for this webinar. And the number one option would be transition planning, partnership planning, and some evaluation ideas. Not sure if you can see the results as they come in. I think we've put it on broadcast now. So it looks like most of you would like all of the above. Well, that's good. So hopefully we're going to cover that today. And I just want to say thank you to Shauna and Joanne, who did all of the work on this in preparing for the webinar today. And just wanted to tell you a bit of an overview of what we're going to talk about. We're going to talk about what is healthcare transition. We will be introducing a linked service model that we've developed through a partnership. We're going to report some of the evaluation findings and discuss the learnings that we've had, and then we have an opportunity to hear your thoughts. There is a chat line, just some housekeeping. There is a chat line that is in your platform, and if you want to ask us a question, those of us who are presenting will try and keep an eye on it so we see if there's a question. If you can't hear, if you could also just chat that you're not hearing it well, that will be helpful. So without further ado, I'm just going to introduce what's the issue. In other words, why are we interested in transition? So transition is the purposeful, planned movement of adolescents with chronic medical condition from child-oriented to adult-oriented healthcare. This is from the Society of Adolescent Medicine, and there's been a great deal of thought about this because it is a problematic area. And for those of you who are interested, it also is a challenge for us to orient the system as well. So the issue is that the ongoing and unprecedented medical advances have led to a new cohort of young adults with congenital or acquired physical disabilities of childhood onset. And they have an ongoing significant reliance on healthcare resources. When they're in the pediatric system, their parents are really their care managers and CEOs. And there are fundamental differences, as many of you are aware, in the pediatric and the adult healthcare environments. In the pediatric, they expect very family-focused care and often parent-driven care, whereas in the adult world, we expect people to navigate the system independently. And so we found in the research that we've been doing and that's published by people like Nancy Young, is that there's poor preparation for people for the changes in the mode of transition in care and also through the transition. So we also know that those of us who work on the adult side of the house, including myself, that adult sector is oriented around typical conditions for the adult sector, like stroke and brain injury that are related to aging often, and musculoskeletal conditions. And so many times the adult healthcare system is not prepared for adolescents who are transitioning because of this. And so we found that available adult healthcare sectors services are often not available or highly siloed. So the consequences, and this has been reported by a study by Nancy Young and others in 2005, is that these individuals have negative adult health and social outcomes. They use the healthcare system much, much more than their age-related peers. It results in psychological distress for patients and their young people and their families. They don't get age-specific, not condition-specific care. and lack of comfort among the professionals, particularly in the adult world, in dealing with these conditions. And this has resulted in a growth of new interventions to promote transition readiness and facilitate continuity of care. But we really don't know what works and what doesn't, and that's why we are here today, is to give you some of our experience. And I'm going to hand it over to Joanne Maxwell to take over. Thanks very much.
Okay, thanks very much, Mark. It's now my pleasure to tell everyone a little bit about the LifeSpan model. David, are you still forwarding slides for us?
I can do it, or you can do it, whichever you'd like.
Maybe hand it back over to us, and then we can do it from our end.
You can go ahead. You're already enabled.
Oh, there, I can see it now. Okay, so as Corinne alluded to at the beginning, LifeSpan stems from a partnership of Holland Bloorview Kids Rehabilitation Hospital and Toronto Rehab, which is now part of UHN. LifeSpan was specifically aimed at addressing some of the issues that Mark just highlighted. What you can't see in the picture on the slide is that these two sites are actually just a couple of 100 meters apart, just really a parking lot apart, which was really actually quite helpful with the partnership. I had the wonderful opportunity to be jointly hired by both organizations in 2006 to support the development and implementation of a linked model for transition. So I can speak firsthand to the partnership and shared vision that existed to improve transitions for young people. The model, as it was conceptualized, was really built upon three key elements. The first being shared management, the second being the importance of opportunities to develop life skills, and the third being the principles of Wagner's chronic care model. Following a pilot in 2007, we were able to receive funding support from the Toronto Central LHIN to support the LifeSpan model, which now serves youth and young adults with cerebral palsy and acquired brain injury. So the shared management model, which I mentioned, was described by Kiefer and Troms, really just speaks to the alliance amongst the young person, their caregivers, and their care providers, where over time the dynamic shifts from the parents directing care to the young person taking more responsibility for directing their own care. As it relates to care providers, shared management really emphasizes the need for clinicians to share their expertise in order to build capacity in the young person and their family. The second principle reflects a recognition that we learn best when we have the opportunity to experience the activities in a real environment, where we can learn from our mistakes and develop transferable problem-solving skills. This is important because the evidence is there that shows young people with disabilities don't have the same opportunities to take risks and try out new skills, such as taking transit or shopping or banking independently, cooking a meal, or interviewing for a job. Lastly, the LifeSpan model was strongly influenced by Wagner's chronic care model, which emphasized things like the development of self-management skills, planned visits over time to prevent issues and promote healthy behaviors, strong linkages and partnerships between care facilities and with community organizations, and the development of needed expertise, in our case amongst adult care providers, and lastly, improved capacity in primary care to manage the needs of people with chronic conditions. The LifeSpan team is depicted on this slide, and I won't go into details, but you can see that we have an interprofessional team and that a number of the roles are cross-appointed, meaning that the individual in that role provides service both in the pediatric and in the adult setting. And we did this intentionally because we felt this familiarity would support successful transition. So you might wonder what the model looks like in practice, and this slide gives a broad outline of the LifeSpan model, which includes a 2-year period of preparation for transition, phase 2 in the model, where clients are streamed in at age 16. Between 18 and 19, clients are transitioned to adult LifeSpan services through a coordinated transfer process. You can also see in the slide that we include a phase 1 that reflects the need for preparation from an early age. While not really a part of the LifeSpan model per se, this early preparation is a critical piece in supporting clients and families. So we wanted to give a little bit of life to LifeSpan. So I'm going to share a story of a real LifeSpan client. Anne came to LifeSpan as a 19-year-old, which is a little later than we like to do now, but she came early in our model. We were trying to catch up initially. Anne had sustained an acquired brain injury at age 8 and had been followed at home since her injury. Anne, at the time, lived with her mom and a younger sister in a single-story home, with her mother managing most of her appointments and booking all of her Wheel-Trans rides. Anne was still in high school and was interested in a career in office administration. She used a power chair in the community and a walker at home. And her clinical presentation included chronic pain, high tone, and decreased fine motor control. There was a neuropsychological assessment report from when Anne was about 17, which identified a nonverbal learning disability, difficulty with initiation and organization, and planning. Anne's lifespan journey started at Holland Bloorview, where the team helped Anne and her mother with things like looking for a family doctor that could see her through her adult life. Many of our clients have a pediatrician. They help them with understanding what it means to have a power of attorney for personal care and for property. They provided them with information about adult funding and ODSP, and an understanding of adult service options, and we helped with making appropriate referrals. The team also prepared a detailed discharge summary and helped Anne to create a personal health record using the My Health Passport tool that was developed at SickKids. Phase 4 represents the official discharge from Holland Bloorview and the transfer of care to Toronto Rehab. And we can all appreciate that this moment in time transfer of care is important, but really a very small part of the overall transition. Phase 5 is where Anne has her first appointment at Toronto Rehab in the LifeSpan service, and typically this occurs about 9 months after the last visit at Holland Bloorview. At her first visit, Anne identified several goals. One was to be able to use a computer at school. She wanted to update her exercise program. She had a goal of building skills for independent living, such as cooking and time management. She wanted to develop advocacy skills, and she was interested in a review of medications and some coping strategies for her medical symptoms. Following that initial visit, Anne was scheduled for annual follow-ups in our LifeSpan clinic, but there's a lot of other elements to LifeSpan as well, all directed by Anne and aligned with her identified goals. As you can see, OT referred to writing aids clinic and worked with Anne on managing her schedule. The physio worked with Anne to update an exercise program. The OT and the life skills facilitator worked with Anne around a cooking goal. She saw a speech language therapist around strategies for reading comprehension and memory. She saw our youth facilitator who provided coaching around the development of advocacy skills, the social worker for counseling regarding adjustment to disability and sexuality, and our nurse practitioner and our physiatrist around health education, management of medications, and referrals to specialists. And also accessed a number of our groups, including Fitness in the City, Moving Out Boot Camp, Self-Management, and Getting Ready for Work. So where is Anne now? Anne continues to attend her annual LifeSpan service appointments, and now she actually volunteers her time to participate in panel discussions with a few of our groups, with the Moving Out Boot Camp and Let's Talk About Sex LifeSpan groups. She's now attending university and participates in extracurricular clubs and university life. She's really well on her way to independence. And at the right there, you can see a picture of our LifeSpan team with members both from Toronto Rehab and Holland Bloorview.
Great, Joanne. So I think that case example really gives you a bit of a flavor of what the LifeSpan model looks like in practice and how it aims to support our clients.
Shauna,
and certainly tells you, about a successful journey that that a young person had. So we really wanted to build on this and ask the big question around, does LifeSpan make a difference if we look at all the clients coming through? And so this was really the impetus for a large-scale evaluation project that we undertook with ONF funding. So the title of our study was called the LET study, which stands for a longitudinal evaluation of transition services. And like the service model and like Corinne outlined earlier, this work was done in partnership between Toronto Rehab and Holland Bloorview by a large-scale clinical research team. So we had a number of key objectives that we wanted to look at in this study. One arm of it concerned a process evaluation, and the other concerned an outcome evaluation. So from the process perspective, this was really a novel model that was implemented, and we really wanted to understand what real-world implementation looked at. What were some of the barriers and enablers to both establishing the partnership, but also keeping the model active and on the ground. And then to inform our outcome evaluation, we also wanted to understand from an intervention perspective, what was the model fidelity? To what extent was the proposed vision realized on the ground? And then ultimately, this work aims to optimize and enhance continuity of care. And so our key evaluation goals were to determine the effect on continuity of care of the introduction of this model, but also to understand how the transition experience had evolved for families who participated. So it was an ambitious project that was 4 years in length and followed a particular cohort of clients through the model. Essentially, we aimed to compare the experience of youth enrolled in LifeSpan, so clients with acquired brain injury, as well as clients with cerebral palsy, and contrast them with youth who weren't in the model. And we identified a clinic that supported our clients with Spina Bifida who were receiving at the time the current standard of care. As I said, the study spanned a number of years, and our data collection was timed alongside participants' 16th birthday when they enrolled in the model up until their 19th birthday, reflecting their pediatric transition prep as well as entry into the adult system. And we employed a number of data sources and stakeholder perspectives to inform the work. So in total, we had 101 youth enrolled that consented to varied portions of the study protocol, 30 ABI, 50 CP, and 21 Spina Bifida, as well as parents for particular portions. Essentially, there was no exclusion criteria that we applied beyond being eligible for the services being delivered. Among this sample, 88% of our participants were born in Canada and spoke English as their first language. Mobility was high among them, with most requiring no help at school. A small proportion did require a wheelchair or a pushchair, less than about 15% for both, and really pertained to our CP and Spina Bifida youth. There were a mix of communicative abilities. Some participants, particularly again in our cerebral palsy sample, did require support from parents in terms of proxy reporting. And most of the study participants had an individualized education plan in place. We looked not only at our clients as participants, but also our key informants in terms of frontline LifeSpan staff, members of related steering groups, and related managers, directors, and CEOs from both organizations to participate in our data collection strategy in order to achieve the aims of the study. So let's look first at some of the data from our process findings around the success of the model in terms of linking care. So within this phase, we conducted 2 rounds of key informant interviews. In phase 1, our aim was to look at the experience of establishing the partnership and really launching the model. And in phase 2, these ones were done about 2 years later and looked at the evolution of the model, including service activities and integration both within the broader healthcare sector and across the 2 sites. And I'll just comment that both the findings from both of these phases have been published, and all of the articles attached to the LET study that we've been successful in publishing are available through open access. So if you'd like to read more, I invite you to take a look at these publications. So I'm just going to give a high-level summary, starting first with some of the successes that were identified across both rounds of interviews. The first really related to the significant commitment that was made across both organizations to realize this vision. Having a partnered model in place that formally linked pediatric and adult rehab was a significant milestone, and one that people spoke to the commitment and passion of all the key members at all levels of the organization that were involved in realizing the vision. not only having a model in place, but having an expert team within the cross-appointed model that was beginning to create a new culture around what care could look like was also seen as a momentous achievement. Over time, growing caseloads of clients both being discharged from Holland Bloorview and being taken on as new clients at Toronto Rehab further validated that the model was filling a gap, and clinicians actively spoke about seeing concrete examples of enhanced readiness and reduced stress among families and clients, and were able to make referrals and continue to link their clients within the rehab sector. And I think the quote here really exemplifies the level of commitment and what a difference that made in terms of realizing the partnership. But with every project and partnership, there's always a few barriers or hurdles that you encounter. And some of the, I've called them sticking points that emerged from the experiences and stories people shared can be classified across 3 different levels: at the client level, at the organizational level, and at the systems level. So one of the things that was noted at the client level concerns variability in individual client needs. So on the pediatric side, there was separate clinics that supported the clients with cerebral palsy and the clients with acquired brain injury. But at the adult level, they streamed into a single clinic supported by one team. And so within each of those clinical populations, there was great heterogeneity noted. And then when they were combined in for one team to support, there was challenges that were noted in terms of providing individualized care, but recognizing the extent of the variability. Between organizations, clinicians noted that there were discrepancies, again, when you're comparing and contrasting the pediatric model and long-standing culture versus the adult one. So the adult team certainly identified multiple opportunities and need for establishing some of the same community partners that were already in place at the pediatric level. So for instance, around the educational system in particular. So really the adult team was essentially creating these partnerships from scratch and building them as they went. Both teams, given the kind of virtual model across the 2 sites, although they were in close proximity across essentially a parking lot, the electronic communication systems within each hospital weren't linked, and ways to facilitate and make that efficient continue to challenge the teams and is something that's still being addressed. And then at the system level, many clients in the model did not have a primary care physician, which put additional pressures on the rehab team to fill this gap. Now, as I said, there was a number of different perspectives that we gathered as part of our data collection strategy. So let's look at some of the other ones beyond our key informants. So from the outcome perspective, as I said, the aim of the model is really to enhance and maintain continuity of care. And we drew on this definition provided by Haggerty and colleagues to really inform our thinking around this important concept. And so the definition really speaks to the idea that there's a series of discrete healthcare events that need to be experienced as coherent and connected and consistent with an individual's needs. So with that frame of reference in mind, we looked to our client records to examine both model fidelity as well as the establishment of adult linkages. And we did this through a formal audit. So with respect to model fidelity, as I said earlier, we were interested in looking at how the model translated to real-world practice. And we collected information that described the pediatric clinical processes of the 2-year preparation window. And we identified 6 criteria that we assigned a score of 1 for each time the condition met. And they really were closely aligned with the model vision. So some examples are that clients would have a minimum of 2 visits within the 2-year period. They would see a minimum of 2 disciplines. A referral to an adult provider would be offered. And as you can see, looking at the graph here, that most of the participants had a score of 3 or higher. So we concluded that moderate model fidelity was noted, and where participants tended to not have a condition met really pertained to having a family physician in place. We did note that there were some participants who were eligible for LifeSpan that were not streamed into the model as institutionally mandated, and so the number of conditions that they met were also lower. So with strong model fidelity in place, we then looked again at our audit data with an outcomes lens to look at whether a linkage had been established. And again, in terms of this data, we identified 3 essential criteria that fit with both our definition of continuity of care and spoke to the broader definition of healthcare transition. And so the 3 criteria we identified were that they had been discharged from the pediatric hospital, a referral to an adult provider had been established, and they had at least 1 visit to an adult provider on or before their 19th birthday. And you can see here, looking at this graph and the 2 columns that are provided in the circle, that only LifeSpan clients with ABI and CP had all 3 conditions met. So there was a clear difference noted between participants in the model and those outside of the model. And the criteria that really set them apart was the first visit before their 19th birthday in the adult system. None of our Spina Bifida participants had this criteria met. So audit data only provides one source of information as it relates to continuity of care. So a big component of our data collection strategy was conducting interviews both with our clients enrolled in the study as well as their parents. In total, we obtained 63 transcripts from interviews that were conducted either individually with youth, individually with parents, jointly parents and youth, and in some cases proxy reporting. The interviews lasted between 10 and 75 minutes with an average of about 35. In total, we had 18 ABI, 24 CP, and 21 Spina Bifida participants. And the conversations really focused heavily on their last pediatric visit as well as the first adult visit, with 3 key themes emerging: enhanced readiness, and emotional time, and bridging the divide. And so I'd just like to spend a few minutes showcasing some quotes that speak to each of these. So in terms of the last pediatric healthcare visit, for both our acquired brain injury and our Spina Bifida groups, most youth reported being accompanied by a parent at their last pediatric visit. However, for our Cerebral Palsy group, there was mixed reports of youth attending independently. Youth and parents could recall discussing what to expect at their first healthcare visit, as well as the need to say goodbye. Across both our Cerebral Palsy and our acquired brain injury groups, most participants reported enhanced feelings of readiness and that they had acquired new skills. And you can see that these quotes showcased here really speak to growing levels of independence and mastery as they prepare for their move to adult services. In terms of the theme around emotions, with respect to the last pediatric visits, all families spoke in an emotional way about this timing. While some parents and youth reported being sad about transitioning to adult care and leaving the familiarity of the pediatric sector, there was definitely elements of being hopeful for the future that were noted. So for example, ABI, our ABI participant here says, "No worries, no concerns, and I guess I was ready because I'm on the right track." Emotions definitely ran higher for our Spina Bifida group. When we started to look at the conversations and stories that were being shared about the first adult visit and how the divide was really being bridged, this is where real significant differences in the experience of our participants in the model versus not in the model really started to emerge. And across all of them, though, even when families felt prepared, some new experiences were still overwhelming. So getting to know new healthcare professionals, adjusting to not having a parent present. But for youth who were in the model, these new experiences and uncertainty around them were really ameliorated through the familiarity of staff, given the cross-appointed model and the early preparation that had been put into place. We did find evidence of positive connections being established in the adult sector among our LifeSpan participants, but for our non-LifeSpan participants, namely our Spina Bifida youth, there were definite challenges in finding care. And so when we look at our audit data at a pediatric prep level, they don't look so different in terms of the supports that were provided, but our Spina Bifida youth and families in the interview transcripts definitely identified less with a transition model, and without a partner already lined up, it was challenging for them to establish formal linkages and make their entry into the adult system. When we look at the transcripts broadly, there was generally an overall positive experience among families for whom connections were established. But we did find instances where not all received the same level of support, not all identified with the model, and continuity outside of rehab was troublesome to establish. But these were small in numbers and provide opportunities to explore why these conditions were realized and look to address them as part of the evaluation recommendations. Some other things that emerged from the transcript was the idea that one size doesn't fit all in terms of offering a transition service and preparation. Certainly we identified some unique experiences that were realized for our participants who had late adolescent brain injury. For many of these families, they had just begun the rehab journey, in stark contrast to our families with a diagnosis of cerebral palsy. And so they were still grappling with the diagnosis and the rehab needs, only to be facing transfer, and this was identified as a significant stressor for families. There was also much discussion and comments around balancing parental involvement, moving into adult services, and youth independence when cognitive impairments were a consideration, and how did families negotiate that as they moved forward. And then finally, not surprisingly, for families for whom English was not their first language, they identified significant struggles during all phases of their transition journey that we captured within the scope of this work.
Okay, so this is Joanne again now, and I get to take us through a little bit of essentially some of the takeaways. So both from the LET study findings as well as our first several years now of LifeSpan experience. So the first one, as Shauna mentioned, was that rehab continuity of care was established. So that is one small piece of the puzzle, but I think an important one. It really is a tiny piece in the overall transition model, but participants in the LifeSpan model did have a visit with an adult provider prior to their 19th birthday, and that wasn't seen with the participants in the study that did not have LifeSpan. So this does demonstrate the importance of an actual service delivery model around transition. The second point was that the findings also support the notion that early education is beneficial in supporting young people and their families as they transition to adult services. And I think most of us would consider this to be intuitive, but the findings of the study and the words of the clients and families really spoke a lot to how important early education was in helping with their transition and their readiness for adult services. While the findings identified that there were challenges to addressing the diversity of needs while supporting client and family-centered principles, Young people and their families that participated in LifeSpan reported enhanced perceptions of continuity of care and generally positive experiences overall. Families who did not participate in the model did not share in these perceptions to the same extent. Loud and clear through the interviews was the fact that there remain significant challenges related to larger system barriers that impede care coordination at a client level. So continued work to address system linkages is needed here in Toronto, but across the province as well. Lastly, transition model or not, transition to adult services is a significant concern for our families and some of our clients, and it represents a time of anxiety and uncertainty. And this may just be the nature of transitions in general, whether it be a positive one or a healthcare transition where the unknown looms ahead. But I think it's important that we all, as providers, as administrators, as researchers, look to understanding how we can better support families and clients through this challenging time. So a final word, I think this quote from a parent in the study really captures that sentiment. You're standing on a rug and you're feeling very comfortable, and all of a sudden someone's tugging that rug a little bit, then they yank it, and you've got to hope that you're just not going to fall over with all the dishes. When there's so much still to be done and so much still to learn, we do believe that LifeSpan holds some promising and important implications for addressing continuity of care across pediatric and adult health services to optimize transition for youth with childhood onset disabilities.
So that is the end of the slides that we prepared to showcase the LifeSpan model as well as speak to the research study attached to it. And so now we'd like to turn the tables over to you and to David as well to moderate in terms of your reflections, your own personal experience, your comments or thoughts on the work that we've shared.
If you could type them into the chat box, I'll read them out to the presenters. We'll just wait a few minutes for people to type. Our first question is from Penny Jacob. Do you involve school staff in the transition process?
So this is Joanne. I'll try to take that one. As much as I'm not a clinician involved in the service model, I know we do involve school staff and student support related staff, both in the high schools and at the college and university level. So often it's our youth facilitator or our life skills facilitator, or sometimes the OT will be involved with school transitions.
Okay, we have a couple more questions coming in. Let's just give them a sec. Krista McMillan would like to know, were there handouts provided by Bloorview staff on what the expectations would be for clients when they transition to the rehab center?
So again, this is Joanne. There were definitely some printed materials that we used to support the young adults as they prepared for transition, and we did provide sort of a package, an overview of a little bit of who the team members are at Toronto Rehab. We also offered an orientation, although I can say not very many people took us up on it. We did have a few clients and families who came for a little tour and introduction to some of the staff before their first visit. So there was some information on what to expect, but I think more importantly probably was the discussion around how it might be different.
One of the publications, I have a list at the end of the slide deck here that lists the work that we put out there, and there's one that you might be interested in taking a look at that gives a detailed overview and breakdown of the different phases that Joanne commented on and the key areas that were highlighted and focused on. And it might provide you a bit more of a breakdown of what the program looked like on the ground according to the model.
Okay, still a couple more coming through. So while we're waiting, I just wanted to thank you very much for putting on this wonderful webinar, including Mark, if he's still there. You guys did a fantastic job.
Still here.
Thank you.
Thank you.
All right, so Janice Hahn would like to know, this question is from Sean Tracy at Bridgepoint. Thanks for the great presentation, terrific project. My question is about how the patients were assigned to the two groups, LifeSpan versus non-LifeSpan. It seemed that the two groups differed by diagnosis, like ABI, CP, SD.
Yes, you're absolutely right. They did differ by diagnosis, and one of our goals with the evaluation was to have a comparison group that we could compare the participants in the model to participants not in the model. But coming up with a comparable matched population comparison group was challenging. So our best strategy to achieve the goal of having a comparison group was to pick a group of young people who were not currently eligible to receive the LifeSpan model, recognize that there was a difference in diagnosis, but also lots of commonalities in terms of barriers and challenges to transition, needs for advocacy, and so forth, and use that real-world control group as our comparison. So I'm pleased to say that in the past, I believe, year or two, our Spina Bifida participants have established an adult partner with the Ann Johnson Health Center and now have a variation of the LifeSpan model in place to support them.
I just add too that our original LifeSpan proposal that we submitted for funding included sort of incremental additions of additional populations, including Spina Bifida in subsequent years. However, our funding from the Toronto Central LHIN was very specifically for acquired brain injury and CP.
Okay, and we have another question from Allison and Christine. Any plans to do more follow-up of the LETS study in a few more years?
So I think we would love to. One of the parameters of our project is that we were only able to follow our participants up until their 19th birthday. And that really just focuses on that, intense period where they're transferring. But I think being able to do a longer term follow-up to look at what care looks like now that they're officially in the adult system and how that might have evolved or changed from past cohorts of young people, I think would be a tremendous contribution to the literature in terms of helping us to understand how we can continue to optimize care when they're fully in the adult system, as opposed to just focusing on bridging the two.
Thanks. And Penny would like to know, how many clients are you currently following and what's your staffing level? Got a whole bunch of questions coming in.
I think we are over 300 clients now, and our staffing levels are still the same as they were when we started, which has put a lot of stress on us in terms of trying to figure out how to manage individuals. Some people graduate to the adult system and after the transition period are able to sort of manage with the support of their family doctor and the supports we put in place. But we found a large number of people still remain part of our team, and so this is a question that we have ongoing. As every year people are graduating from Bloorview, how do we manage ongoing and we're certainly stretched a little bit, but I think it's been useful for us to understand, you know, and have the experience of helping all those 300 people. I don't know, Joanne or Shauna, if you want to add anything to that.
I think it's actually probably over 400 now. It's about 60 clients a year who are being discharged and transferred from Holland-Bloor-View to Toronto Rehab. So I would echo what Mark said, although I think the clinical team could really speak to some of the stressors. I think the last few years there's been a lot more emphasis on how do we help people graduate from LifeSpan and independently manage within the system. But as Mark said, there's some clients who need some ongoing management, and the adult system isn't quite yet ready to meet all their needs.
Thank you. And here we have, Jan would like to know, could you speak to the training on the adult health care team side? How was the shared management model introduced? Any training or experiences you can share?
Do you want to answer that at first, Joanne, and then I'll comment on it?
Sure, I can speak a little to the early years. So for the shared management principles in particular, we really relied on some of our staff at Holland-Bloor-View who've been heavily involved in the development of some of the growing up ready materials that are used here, and really quite familiar with the shared management model. So we did a lot of sort of cross-training of the teams. As new staff members were brought on, they spent a lot of time with the pediatric team understanding sort of the principles of that model and understanding what the pediatric care model looked like as well. You know, it's interesting to try to do training when there really wasn't a lot of adult expertise per se, but there was a lot of ongoing learning. We had a better sense of what the acquired brain injury clients might need because Mark was already following a number of young adults as they transitioned into adulthood. But the CP group, there was a lot of learning in the first few years.
I think if you were doing this again, I think what I would suggest is that any adult provider learn from the pediatric providers. I certainly found it was very helpful to talk to people like Darcy Feelings and Golda Milo-Manson, who were taking care of these individuals and just understanding what they saw was the priority. So I think it is a need for the adult providers to reach out. And I think there's also some things that we learned that maybe the pediatric providers might not have known about, you know, the high prevalence of pain, the frequent issues with psychiatric and psychological complications that emerge as people grow up. And we've learned a lot about that as we've gone forward. So I think there's a need for some experience in the adult world, but I don't think that the pediatric folks can completely provide us with all the education because there's unique problems that occur in the adult years.
So here we have another question from Lori. Are you able to predict an average number of adults once the process is stable, like 10 years? Our adult providers were surprised by the sheer number when we proposed a clinical transition, transition clinic model.
I think that's,
yeah,
Mark.
It's really hard to know. I would have to say that our experience has been that it's only probably about 10% to 15% that actually we so-called discharge and let them go. I would also say that there's a large proportion that we follow once a year. So once you get to stability, they still like to have an expert provider who understands their condition, see them at least once a year. So I think that when you're planning, it's safer to plan with most people receiving at minimum a once-a-year visit. Joanne, I don't know if you want to add anything to that because you have some experience with Spina Bifida as well.
Yeah, I think, I mean, obviously resources are a huge component in identifying how you're going to deliver services long-term. I think as the program matures, as we get better in pediatric care, preparing families, as the adult health services start to develop more around chronic management of disability, there may be opportunities to discharge more of our lifespan clients. But we're still in, although it's 8 years in now, we're still in early years in terms of building that capacity in the adult sector. And I think that's why we still see so many who need and want, but need some ongoing management. We're also still, very focused on supporting some of the care to be happening in the community, so developing expertise and capacity amongst primary care, and maybe with some of the development around primary care teams and some of the other networks that are developing in primary care, there may be opportunities for better management of chronic conditions like these outside of the hospitals. And I think that's where we should all be trying to get. Mark, living the experience now of a lot of people still needing lifespan management.
I see that Lori was asking about if we've identified some common service gaps, and particularly medical specialties that are required beyond physiatry. I'd have to say that the most surprisingly, in terms of our clinical experience, I'm very grateful that Andrea Lozon, our nurse practitioner, has a strong background in psychiatry. I think the biggest thing for me that surprised me was the number of psychiatric and psychological issues that are arising, people having first onset of psychosis and depression. And I would have to say that having access to neuropsychiatry in this population appears to be a very important area. And I also think that pain management has become a very important area, and sort of linkages with orthopedics and other pain management providers. We've had a number of our population go through our pain management program, and so it's very interesting that these things are things that are very interesting to see as problems. I think a lot of what I would tell people is that a lot of the focus in the pediatric world is on getting people up and walking, and it's important to note that that has consequences for people who don't walk normally. We have a number of individuals who are in quite a bit of pain because they are upright, but they're walking with problems with their hips, problems with their back, and I think we need to think about pain as an important concern as we feed that back to our colleagues in pediatrics, that the focus on independence should not just be on mobility but also on true community independence. So I think that would be my observation. I don't know, Joanne, if you wanted to add anything, because I certainly think we've had some interesting experience.
Yeah, no, I think that captured it well. The other specialties that I think we've created strong linkages with are around neurology and urology, would be the other medical specialists. But I do concur with the notion that there's a lot of mental health, a need to be addressing that as well.
Okay, I think we're going to make this the last question to wrap up. So we have a question from Carol. I like the idea of a transition clinic model with shared management staff to bridge the gap between youth and adult services. Unfortunately, we run into some difficulty with children's treatment centers mandate and funding coming from the Ministry of Youth and Services and adult programs being funded via the Ministry of Health and Long-Term Care, MOHLTC, and the LIM. Has there been any dialogue around how to implement your model in this type of scenario?
I guess the answer is we had it a little easier because we're both Holland Bloorview and Toronto Rehab are funded under the Ministry of Health and Long-Term Care, and actually both within the same LIN. I think our experience with the newer Spina Bifida model is at least outside of hospitals, so looking at community health centers as a partner, and that was a different experience. And you do look at different cultures, different funding models, different service delivery, and I think your example of a children's treatment center and then adult services within the health sector is even more challenging. I think that the struggle overall with this whole thing is who should be the funder. A lot of the really important aspects of lifespan maybe aren't health related or medically related, and maybe there's opportunities to work with other ministries to support some of the service delivery. I think if your starting place is looking at an adult hospital to provide medical management, then I guess it's around, creating those personal networks and connections with the folks in the hospitals to then work on how you identify a strategy for creating a proposal.
I think one of the other things that we would like to do is, and we're doing some work on, is understanding can we reduce healthcare utilization? Because the arguments that we would make is that if these people get appropriate care, then they will, you're taking care of them already in the emergency room and family doctors, and if we can instead take care of them appropriately, then I think that's the argument, and that's what I think we need. If future research was here, I think we need to look at comparing those who are treated in a transition model to those who are treated in routine care, and we are looking at that already, but I do think that that's the argument we're going to need to take to the LHIN and to the ministry, because I believe that they don't realize that they're providing care, but they're providing care that's not best practice or not ideal, and so they're ending up costing more than they should because they're not getting the appropriate care in the timely fashion. If it's okay, David, I'll just notice that Jan also asked a question about should we stratify young people in terms of their transition readiness and or needs? I don't know, Shauna or Joanne, from the pediatric side, do you see that there are different readiness, and we can maybe talk about how we receive them when we get them in the adult world?
Yeah, I think, and we've had some discussions, I know, over time around that question of transition readiness, and certainly our experience in LifeSpan is that many of them are, it's hard to define ready, but many of them are doing those readiness preparation activities in through early adulthood. So whether or not you can actually really prepare young people for transition is, I think it's a longer process than we can maybe manage in pediatrics. Whether you could stratify around clinical needs, I think maybe Mark could speak to this, but there probably is opportunity to look at service delivery models that are more geared to specific needs of a population, particularly around medical management. I do think that there's some opportunity, and I know there's some work out of Canchild around looking at transition readiness. And I think certainly that work can inform what we need to do on both sides. So a transition model is not thinking solely specifically about age, and I think Shauna mentioned it's not so age specific, but there's a lot of activity that has to happen, and maybe we could learn more around those transition readiness issues, but not specifically as it relates to pediatric or adult care.
And I'll just add that transition readiness was one of the outcomes that we were interested in looking at when we launched the study, and we looked at a number of different measures. We tried using the Partners in Health scale, which was kind of one of the better ones that we were able to identify at the time, but the feedback from our participants is that it really wasn't excuse me, a good fit for their healthcare needs. So I think they're, hearing Mark talk about clients on the other side who, are able to manage their care and they can almost graduate from the system does suggest that people, have different trajectories in terms of their transition readiness. But I think to Joanne's point, we need to be mindful that there's not a finite window in terms of when these skills mature, and then also ensuring that we have, the right measures that would allow us to effectively and appropriately stratify as you suggest. Mark?
Yeah, thanks, Shauna and Joanne. I would agree. I think what we see is that some people you can stratify by they have a large number of medical needs, and you can see their complexity, and I think that that's one group where we could see that there might be some ability to sort of say this person has got a lot of equipment, they've got a lot of medical issues, they've got a lot of specialists involved. That's easy probably to flag. I think the less easy to flag is the developmental readiness, which is we see a high variability, particularly in CP, but also in the TBI population of ability of individuals to take on the role of their care cognitively and emotionally, and certainly, and so I see that stratifying people for their medical needs might be easier than their development needs, but I agree with Shauna that we don't have a tool yet that sort of tells us who's who when it comes to developmental readiness. My light went off. So I don't know, there was a last question, I guess. Are you using any standardized tests for quality of life tools? We aren't using them routinely, but certainly as a LET study, we have a number of tools that we did incorporate in the quantitative data.
Yeah, we gathered some data using the Life-H, the Partners in Health Scale, the self-management tool, I believe, self-determination, the ARC measure. Trying to recall.
Yeah, I think if someone was specifically interested in that, we could
follow up.
We could provide a list of the outcome measures that were used as part of the study. But as Mark said, there aren't any that we are specifically using in a standardized way in the clinical service model. It could be an improvement, I think.
They are in the protocol, which is published, which if you go through the slide deck, it's published in BMC Pediatrics or BDMC Neuro. Anyway, yeah. So it's on the list here, and the protocol has all the tools that we're currently using in the study. So should we wrap it up, David? I know there's still questions coming in.
I think that's it. Thank you very, very much to our presenters, and thanks to the audience for joining us, and thanks to everyone tuning in on YouTube afterwards.
Thank you.
Have a good day, everyone.
Want to follow up with us? Our contact information is there on the slide, and we can also direct you to Mark very easily.
Thank you.
And I'm going to type my email in the chat so you can email me if you'd like slides or have any questions.
Great. Thank you so much for facilitating, David.
No problem.
Bye-bye.
Bye now.